Thank you, Charles. Thank you very much for your kind invitation and introduction. I've enjoyed my first meeting so far, and I really enjoyed the last two talks, in particular Dr. Major Senior's and Dr. Beyond's talks. So my brief is to discuss the ethical issues surrounding immediately sequential bilateral cataract surgery. I can't give you all the answers, but so that there will be more questions than answers. I have no financial declaration. There is a misspelling there, I'm sorry. The advantages of ISBCS are well rehearsed, so I won't go through with those. The strategies that I have adopted over many years are case selection, change of instruments and intraocular substances, and a non-ballistic approach, so if the first eye has not gone well, then the second eye is deferred. Earlier this year, hosted by the Royal College of Ophthalmologists, we had a 3.5-hour debate on the ethics and religious views and medical legal views of immediately sequential bilateral cataract surgery. So we had 3 ethicists and 3 religious persons of different religions, lawyers, a health economist, the chair of NICE guidance, college officers, surgeons for and against, an optometrist from the College of Optometrists, and a number of patients and a lay person. So we had 3.5 hours of that, and one day when it's complete, then I will post the whole thing on YouTube for you to watch. So these are the things that we discussed, and also I'm going to go through things that we hadn't discussed but I have been thinking about. One thing for sure, the patient should have a choice. If they want to have bilateral, they can have bilateral. If they don't want to, then nobody must force them. However, it was the view that all options should be considered and discussed with the patient. So it should be considered and discussed with the patient. Even if it's not suitable for them, it should be mentioned and then dismissed. In terms of consent, we all know how difficult it is to get true informed consent because they really will not understand all the ins and outs. So you can imagine that's very difficult for unilateral surgery. How difficult is that for ISBCS? And it was suggested that maybe an app should be developed so that patients will go through one step at a time and they deal with all the learning, and then when they come, then they can sign. So in terms of medical legal, it is being done, so you can offer it, but if something goes wrong, then you have to be able to answer all the questions that you've done everything properly, you've discussed properly, and everything is documented. Otherwise, you won't have a leg to stand on, because lawyers are very, very clever people to find any loophole to get you. Well, there are many people, many surgeons who object to ISBCS, and they can do that. No surgeon can be forced to perform anything that they do not want to do. However, it is still the surgeon's responsibility to discuss all options, including ISBCS. The money side of things, we do save money by doing the 2 operations at the same sitting. There's a lot of cost savings to hospital, societal, and also to patients and carers. So obviously we have the prime concern is the patients in front of us, but also we have a higher responsibility to make sure that we do things in a sustainable way and that we save money for society as well. Because there's only a limited pot of money in any society, and what is saved and not used can be used for something else to provide other healthcare for other diseases, either in ophthalmology or cancer or pediatric or what have you. But don't expect to see that the money saved will come back to ophthalmology or to come back to cataract surgery. You're saving society money and it can be used somewhere else. The Catholic view is that the poor and the helpless should be given priority. And they also think that, I'm Catholic, so I also think that we need to conserve funds for society. Sustainability, just talked about that. We create 2 queues where there is a state-funded system, when there is a long waiting list, then if you are doing more eyes or fewer patients, then the number of patients on your waiting list will grow. However, this is temporary because once you've got over the blip, because you're actually doing more eyes per list, because it's more efficient to do bilateral, the waiting list will in turn, over a few months, come back down to what it should be when the second eye patients don't come back to have surgery. Training. Some surgeons say, well, if a senior surgeon has to do all the operating, then there will be no training cases for the trainees. However, there is nothing to stop trainees operating on the second eye of bilateral cataract surgery. Further, senior trainees who are competent can actually operate on both eyes. It would be a lot easier for nurses if manufacturers can be encouraged to produce left packs and right packs that they can just pull out from the shelves rather than look through and say, oh, this batch number, that batch number. So who can offer ISCBS? Obviously, good track record of the surgeon and good track record of the hospital. So people who are not very good surgeons operating in hospitals which are not very clean should not be offering ISCBS. I believe case selection is important, and obviously if you're very, very good, you can operate on rock hard cataracts, but if you're not, then perhaps you shouldn't. So then, one thing which was discussed was how safe does it have to be before it's offered? It's very difficult to do any randomized controlled studies or trials because the complications rate is actually very low if we're talking about endophthalmitis. So you need a very, very big study, which is almost undoable to prove the safety. The consensus is that we can go ahead gradually and see what happens and then modify how we offer this sort of service. Then there is fear to deal with. Surgeons may be fearful, especially those who feel that this is unethical. And patients fear too. That needs to be considered.
1 minute, please.
In terms of recovering from ISCBS, there is some extra recovery. Even though the two eyes are recovering at the same time, it is more arduous for the patients because they haven't got an unoperated eye for looking after themselves or putting the eye drops in the other eye. That is often not considered, and it was actually one of my co-workers, Mehran, who brought this to my attention. Then there is a fear that we may be doing an unnecessary second eye operation. For sure, we will offer this to bilaterally visually significant cataracts, but there will be some that, if they have been offered unilateral first eye surgery, that they'll be quite happy and not proceed with the second eye. Whereas if it's already programmed to go ahead, then it is feared that there may be some unnecessary operations. In terms of which eye to operate first, usually the worst eye. But if the worst eye is at higher risk of complication, for example, white cataract, then maybe we can do the easier one first and give the patient a better chance of having both eyes done. However, are we actually cheating ourselves, fooling ourselves? More or less to find the slide of uncertainties, we don't really know the true risk of bilateral endophthalmitis. It seems to be very low if we're careful. However, it has been alluded to, if something happens to one eye, it's more likely to happen to the other eye of the same patient because there is something peculiar about them, or something peculiar about the operating conditions of that particular moment. So therefore, if one eye develops endophthalmitis, the other eye is actually more at risk. In terms of cystoid macular edema, not all cases resolve altogether, so that is also, in fact, a bigger risk than bilateral endophthalmitis. Biometry error and refractive surprise, I don't think they're real concerns, so that's why I put that in brackets. So I presented concepts arising from this very long 3.5-hour debate and my personal thoughts. We have a duty to do our best for each patient, but also a duty to society. So choice, consent, safety, collegiality, but not cover up for our colleagues, are all important. Thank you very much.